Hey, folks, if you want early access to episodes as they drop, click that subscribe button, join us, and together we'll fix the broken U.S. healthcare system. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I am here today with the lovely Dana Mincer, DO. I'm not really sure what that is, but she's going to tell us. Welcome to the big show, Dana.
Thank you for having me. I'm honored. I've been waiting for this for a long time. Since we met, I was super excited.
You are gracing us with your presence, and it is me and our audience that are honored. So
I feel the same way about you. So thank you.
Wonderful. Well, thank you for being here. So let's actually start there. Like most of the times I hear MD after a doctor's name, and you're a DO. So what is the distinction there? Does that make you a lower level person, a higher level person? Has it got nothing to do with that? Is it just about kind of your path versus the typical path? What is that distinction? What does it stand for?
I guess it depends on who you're talking to, right? It's all about perspective in life.
Yeah.
So it's doctor of osteopathy.
Okay.
I was older. I was 28 when I started med school. And so I was a non-traditional student. I did nothing with science or medicine in undergrad. I graduated from Franklin College in Lugano, Switzerland. It's like this tiny little liberal arts school. And I had to go back to school once I realized, I think I might want to do medicine to do all my prereqs and everything. In the meantime, when I was living in the Italian part of Switzerland in Lugano, I, as a former D1 athlete, I always just had a lot of like body aches and pains. Mm-hmm. And I became friends with an osteopath in Europe, in Switzerland. And he treated me, and he was a friend of a friend, and really, helped me a significant amount. Showed me the relationship between, just like the mental, physical, and spiritual, right? Is what comes first? Is it that you're sort of like not feeling well mentally, and then your body starts to hurt, or is your body hurting, and then or is it just sort of cyclical in nature?
Yeah.
And so that got me looking at osteopathic schools in the U.S. because I realized that was an option. I think historically there's been some. Well, I guess it depends on who you're talking to. There's been some looking down upon osteopathic institutions. I did both sets of boards. So I did the MD boards and I did the osteopathic boards. And each board exam is about 8 hours, and there's level 1, level 2, and level 3. So for level 1 and level 2, I did both sets of exams just so there wouldn't be an issue for me like going into a residency program. And now we're at a point where I think they've like combined most of their programs. The education is the same. We just spend more time in the lab. Like we actually spend time. The simplistic version is osteopaths are sort of like, it's like a doctor meets chiropractor in a way, but we just it's a lot of training.
Yeah.
And if you go to an osteopathic residency program, or historically when you went to an osteopathic training, that training would continue. So you'd have hands-on training. Now, I would say I don't offer that that's a separate pay grade structure, I think, because it requires a significant amount of extra time with patients. And I have an osteopath who I refer patients to who's not far from my office, just for body work, hands-on manipulative treatment.
Gotcha. So interesting. I'm always fascinated by the path of folks, and particularly when, you're a kid and you're trying to figure it all out. What do I want to be when I grow up? That sort of thing. And then when you get to medicine, it's I think very often doctors and lawyers are kind of lumped together. And the reality is the amount of training that it takes to be an attorney versus a doctor is night and day. It's like there's no comparison. Like the docs, you're basically in it for like 14 years, right?
It's a long time.
And you go through residency and all of that. It's crazy to me. So anyway, I don't want to bore the audience with those details. So we met when we were out in Oklahoma City
At the pool.
at FMMA.
Well, I think I told you, I said, hey, we're going, we met you in an elevator, I think it wasn't it? I was like, we're going
Sounds
to the
about
pool.
right.
You should come out to the pool for
Right.
lunch because we should see daylight.
Yeah.
And you're like, actually, maybe I will.
It's a good idea.
And then you met us out at the pool.
Right. I was like, let's see. Go sit in a boring hotel conference room and listen to someone drone on, or hang out at the pool with Dana and her fiance. I was like, I'm going to the pool. So, yeah, that's
We
usually.
weren't even drinking.
This is true.
Right.
Sadly.
Yeah.
But hey, listen, I've been practicing sober October, dry since October 1st. We're doing good. But so, it was fun hanging out with you guys and getting to know a little bit about what you do. And it's interesting because you're, and I don't want to put words in your mouth, but I think what resonated with me, and for those of you who don't know, Free Market Medical Association was founded by a couple of guys, one being Dr. Keith Smith, and he has a partner, his name escapes me, the guy who runs the TPA.
Yeah.
No discredit to him. It's just, we haven't met and talked and that sort of stuff. But he had a partner that they launched Free Market Medical Association with. And the guy, I think it was Kempton. Anyway, the idea was, not to kind of plug the show, but our healthcare system is broken, and we think there's a better way. And
Yeah.
what they were focused on was really healthcare being a free market, having a supply chain, and why don't we start an organization and show people that there is actually a way that they don't need to rely on insurance, and there is a path to higher quality, better rates, which sounds like fantasy to many, many people until you really kind of dive in and pull back the layers. And so Dana's out there at the pool and she's doing like all these stretches. I didn't know she was a doctor at this point. She's like stretching, doing yoga moves, and and again,
Moving my body. By the way, everyone needs to be doing this.
Okay, well she was doing it, and it got my attention, and I was like, okay, she's there, and we're hanging out with Tommy, your fiance, and I was like, we started talking, and I said, what do you do? And you kind of told me, and I was like, oh, wow, that's pretty cool. And the idea is you're there looking for alternatives to the system. And whether you're a patient or a physician or a surgeon, we're all kind of stuck in this system. And I believe, and again, I don't want to put words in your mouth, but you and you and Tommy were there to say, is there a better way to do this? Can we? And I believe it was, you're pretty early in your journey still, but you were out there saying, on a quest for like knowledge. Can we do something about this? Can we break away? And folks, there's so much mergers and acquisitions going on, and private equity in the space, and hospitals buying private practices, and the people in the middle, including the doctors and the surgeons, are getting screwed. It's the big entities that are kind of laughing all the way to the bank. And so, how did you stumble on the Free Market Medical Association? What kind of sent you down that path?
That's a good question. So I had been toying. I always say, I joke, I had been stalking the other DPC doctors for like 5 years, right? Because I was single momming for a while, and I had a young child. I mean, my daughter's now 7, the youngest, and I couldn't fathom opening my own business. Like it takes a lot of work, right? Like the idea of DPC sounded amazing to me, but the idea of starting my business with an infant at home, and so I think when Tommy came into my life, it was really helpful because I now have not only a partner who's very supportive, but I also have someone who's like a genius CPA, right?
Yeah.
Which, and
that's important. So that's kind of the yin to the yang. Like what I've learned, and not to disparage you or any of your colleagues, but doctors typically are not the best. They're not business people.
No.
Right? So if
we
you
know nothing.
If you have a partner that's in your personal life that can help you with kind of the X's and the O's and the pluses and the minuses of the business side, that's a huge advantage.
Yeah, 100%. And I don't really remember. So I opened my practice, it was about a year and a half ago, and I don't really remember I can't off the top of my head what got us to the Free Market Medical Association. It was on the top of my list. I think I had just been doing what I usually do, which is like talking to as many people as possible and asking questions. And that's how we got there, because we realized that was super, super important. So I don't know if that exactly answers your question, but
Yeah.
And Tommy was fed up too at the time. He was
Just get a little closer to that mic.
Yep. Is that better?
Yeah, that's much better. Great.
So Tommy was fed up too at the time because he was always in corporate. He was doing he wasn't. When I say CPA, people think of like, oh, taxes. He's doing my taxes, but he's never actually done taxes. He's always done corporate financial planning, projections, and things like that, and worked for large corporations. And the last one was a corporation that was acquiring, like doing millions of dollars worth of acquisitions each year. And I grew up in a small family business and experienced this firsthand. What happens when acquisition happens without seeing the sacred humanity below you, right? So people, like these large corporations come in and they don't see the humans below them, and they just rearrange everything, and that includes destroying people's lives, and they just don't give a shit.
Right.
And he was looking for a way out as well. He didn't know exactly what he was going to do, but he knew that was not in line with who we are in the world.
Right.
So I think that started him sort of down a path of really saying, yeah, I think that you should go for this. I think I can help you with this. And, now we sort of pair that with him helping or attempting to help make contact with businesses as well. And we just needed to learn more. I don't know that we'll ever be like directly in the brokerage space, but like we're both considering going through the Health Rosetta trainings, and because we need to understand this. And once you wake up and you open your eyes and you see this, you can never go back to sleep, right? It's like you see the absurdity of what's happening, and you can never go back.
Yeah, it's true. It's when you look at what is going on in the space and you see it, you can't unsee it. And what you see is just it really boggles the mind. It's like fantastical, right? Like, how could one person pay $100,000 a month for a drug and someone else get the same drug for free? Well, does the person that's paying $100,000, and the problem with the system is the patient typically is not exposed to the true cost. They only know what their fair share of the cost is. So if they have a copay or a deductible to meet, that's what they're focused on.
They don't even know that. Half the time they don't even know that because their plans are so convoluted. And can I curse on this show?
Absolutely.
They don't even know that, and it's not their fault.
Yeah.
The doctors don't even know.
Yeah.
I mean, that gets us down what we were talking about earlier, the path of like, just recently I've been trying to get reference-based pricing, or just what is the actual cost of your service, right? Like, I know what a car is going to cost me before I buy it. I know what the apple at the supermarket is going to cost me before I buy it.
Right.
I know what a pair of shoes is going to cost me before I buy it. Like, why can we not get that pricing easily from other doctors? And so I've been attempting to work with groups around me and directly working with the doctors. And there's so much misinformation and fear. And I will say it like it is, because of this health insurance cartel. It is one of the largest legal cartels that could have ever existed. And I told you the story earlier about how, like, I was just trying to get reference-based pricing from this local practice. They have 11 physicians within the practice, and it's a specialty practice. And I said, just give me the cash pay cost. We can't do that. We can't do that because that's illegal. That would violate our contract with Blue Cross. And I said, to hell it will. I mean, I'm not a lawyer, but listen, why don't you get some legal advice from some of the states that have gone before you, Oklahoma, Wisconsin, Texas. Go get a lawyer from there to help inform you. I'm not a lawyer, but what I can tell you is the one thing that you can say to the insurers is, fine, you pay me immediately right before the service happens, and then we have a problem. But that's not how you're paying me. In Pennsylvania, we're chasing payments from insurance reimbursement up to 90 days.
Yeah.
So like that is one of the things that I saw was happening, and he still couldn't come around this doctor to like giving me pricing. He's like, I guess we'll, I'd love to stay in touch, but like he just basically ended the conversation.
Yeah.
The other absurdity was like we were trying to negotiate with one of the few independent health systems that's left, right? And we need independence in Pennsylvania desperately, because right now Jefferson, if you find me dead, I guess you'll know who did it. But Jefferson and Penn is coming in and buying up everything, and the care is absurd. It is horrific. I can't even send people to the emergency room locally anymore. It used to be an incredible hospital, Abington Hospital. Because I can't get a hold of a doctor in the emergency room. I can't get through the phone system to say, hey, I'm sending my patient over. I need to give you sign out. That's important, right? Like, there's a reason why I'm sending my patient.
What is sign out exactly?
Sign out is like, if I'm sending as a primary care doctor, if I'm sending a patient as a DPC doctor who has time now, right? Like, this is not a 7-minute visit. I've even done, let's just put it this way. In a typical primary care setting, insurance-based, I wouldn't have had time. So, like, I would have a patient that had strange symptoms, and I would just be like, you have to go to the emergency room for a head CT, because I wouldn't want to deal, and I wouldn't have this time or resources to deal with getting that CT scan done.
Yep.
Now I have time. So I had a patient, for example, that woke up with the worst headache of her life the other day, and I know her well. I had time to spend on the phone with her. I had time to call the local imaging center that I have a partnership with and say, hey, you can get my patient in for same-day CT, right? Boom, over for a same-day CT. We were able to get a read on it within an hour, and everything was normal, and that ruled out any major issues happening, and then we were able to deal with the underlying headache at hand.
Now, I want you to pause on that for a second, because in a traditional model where docs are overloaded and you're basically under incredible pressure to see a volume of patients, an enormous volume of patients, and, keep track of all of them and get the info into the EMR and all of that crap, there's no opportunity for you to take the time that you did and reach out and have a peer-to-peer and say, hey, my patient's coming over, and here's what you need to know, and get her in, get him in, and, this is important, and it's potentially a life-threatening, find. So we need you to do the diagnostic test, and we don't need you to put it out 6 weeks, because we may not have 6 weeks.
And I also think it's like, I'm saving your ass as the emergency room doctor as well if I'm sending somebody over by giving you sign out. Because, again, because I have time with patients, I'm not sending people frivolously to the emergency room.
Yeah.
I'm sending people that I know I can't help at an outpatient level. Like, there's nothing for me to do.
Yeah.
Because it's not a lack of time. It's just like they need a D-dimer test, which is a test for a blood clot, which can't really be done outpatient very well. Or they need, now with CT scans I can get them, but if I'm thinking they're having a heart attack, right? I'm sending them over for that reason. So I'm saving the doctor's ass too by just getting a hold of them saying, I'm sending this patient. You need to make sure that this patient makes it through your triage.
Get ready.
Because half of the battle is like you get into triage, and these are just like, no offense to nurses. I think nurses are the, Mother Teresas of the world in so many ways, but the level of training is also different. And so there's just protocols they go off of like taking vital signs when they're triaging you in the emergency room. And there are people who slip through and they don't make it in. But that's
huge. Just having the ability to make those calls. It's not that, I'm sure that doctors practicing, in the traditional model would love to take the time to make those calls. They just don't have the time.
They're exhausted. They're over. Like, I thought I wanted to quit medicine. Let's just put it that way. I went back to school at 28 with a 6-week-old infant in tow. And I'm like, I didn't do that for nothing. Like, this was something bigger than me. And I truly believe that what we are doing, and even though it's like, you know how it is, you're like climbing up a mountain constantly, or you're, another doctor I know, she says, I was screaming from a mountaintop and like nobody's listening, right? But I really feel like this is a calling. This is not, I'm just like, I'm listening to my higher power, and I'm just saying, what do I need to do next, right? But I didn't go back to school for nothing. And I was about to quit medicine because I was so burnt out. That provider fatigue is so real.
So wait, you said you went back to school at 28, did you say?
Yeah.
And so what was your training up until that point?
I had an undergraduate degree in visual communications.
In visual communications. So you could be a graphic designer? Kind of, sort of, and maybe.
And I did some marketing, and I taught Pee-wee tennis. And
so what in God's green earth made you say, I'm going to be a doctor?
I think, it was funny. I think like I grew up in a culturally Jewish family, so it was like they always make that joke like, oh well, I had options. My options were I could become a doctor or a lawyer, right? Like,
Oi.
yeah, like yeah, you have options.
She could be a doctor
or a lawyer.
or a lawyer.
Yeah.
If she's a little retarded, maybe an accountant.
Yeah, right. Exactly, right.
Right. Yeah, that's the joke. I think.
Yeah. And
that's funny.
Yeah, and so something changed in me. I think just going through my own health struggles, and this is definitely more serious, so we're taking a turn on this one, and I don't mind talking about this. I think this is really important. When I was in my late teens and early 20s, I suffered with this horrible depression, anxiety, and an eating disorder. And I experienced the system through and through. I mean, there was a week where I was hospitalized. I was inpatient because I was thinking about taking my own life because I was just frustrated and fed up, and I didn't think I was going to get better. And I got all this horrific care, and I got all this amazing care. And I think going through that experience and moving through it and getting better was sort of the start of me saying, okay, maybe I want to do this. I mean, I know I had my mom in the background saying, you'd be a great doctor. When I was younger, you'd be a great doctor.
Yeah.
But I didn't, it takes a certain level of discipline. And man, you really have to work through your fears, because there's always that fear of what if I don't get a good score on the entrance exam? What if I don't get into med school? Then once you're in med school, it's not solidified. You still need to get into residency.
Yeah.
And it's a lot of pressure, and it's a huge sacrifice. So I think it just took me a while to figure out that it was what I wanted to do. But I couldn't see myself doing anything else.
So let's unpack that a little bit. I'd like to dive deeper into that, because you experienced anxiety, an eating disorder. You had some mental, emotional issues and demons that you were facing. And I think, even today in this day and age, that stuff, just kind of gets swept under the rug, and, no one thinks about, going to see someone to talk to them. It's still kind of frowned upon, which is terrible, because your brain is arguably the most important part of your body.
Yeah.
Certainly right up there with the heart.
Yeah.
Right?
Yeah.
And
men might say differently.
Well, that other organ that just always gets us into trouble.
But it's technically connected, so.
There we go. So you're in this you're in this prison that is your mind, and you're suffering. And so what was the impetus that it caused you to seek care? And, just kind of take us down that path a little bit, because if I heard you right, you said 14. And so that's high school age. There's a lot going on. There's a lot going on. You're coming into your own as a woman, high school, pressure's on. And I don't know if you were contending with social media to the extent that we are today. I don't know if that was a component of it or not.
I'm old. I'm 42.
Oh, that's... Please.
I'm age gifted.
I would give my right nut to be 42. But I digress.
Yeah.
Tell us a little bit about what you were going through, and what that path was like, because it's fascinating, because you're a doctor, but this is your experience as a patient. So I'd love for you to share that.
So, and this is interesting, because I was talking to another physician. Who was I talking to? Man, I'm sorry if you're listening to this and you remember, but I was talking to somebody else, and it's like mental health is one of those taboo areas that I have been insistent on talking about. My personal story, because I think it's very relatable and it's helpful. But, there used to be, when you try to get your state license, they would ask, some of the state licenses still have that. Have you ever had any mental issues or
really?
Mental health issues?
Really?
And it's what? That's, anyway,
Yeah.
That precludes you from being a doctor. But so when I was diagnosed with attention deficit. So
Okay.
I also have a different perspective that it differs from the standard Western diagnosis of, if you have attention deficit disorder, you should give your kid a stimulant. I differ on that.
Yeah.
That
was an argument between my wife and I for a minute, because my son was bouncing off the walls when he was a kid. And, she thought that maybe it would help him kind of focus and be grounded. I was vehemently against that, just because I was like, we didn't need this shit for, however long man has been on the earth, 10,000 years, 20,000 years. What the hell do we need this for now? Leave the kid alone. And I'm sure there are cases where, it may be a help in extreme cases. I didn't think my son was fitting that bill, and I was just like, teacher's going to have to deal with it. And
we have the same story, except I had been fighting with my ex. So,
yeah.
Well,
luckily we came to agreement and we didn't, medicate him.
Yeah.
But that's not an easy one.
No,
right?
It's a very difficult one, especially given the way the school systems are constructed. We went off on a little bit of a tangent here, but I could talk for a long time about that. Like, we need our kids to have outside time. There's a reason why they're bouncing off the walls, and I am vehemently opposed to just handing out stimulant medications. I had a psychiatrist tell my ex that you would give your child medicine for their diabetes if they had diabetes, and I'm just like, what? There's a difference between
needing
you
insulin.
have to give insulin because you will die of high blood sugar,
right?
And giving a stimulant you're giving speed to a child.
Sure,
it needs to be very carefully thought out, and I agree in those extreme circumstances.
But the other issue is, Dana, or should I say Dr. Mincer?
No, everyone calls me Dana. I
Dana.
only introduce myself as doctor. I think I told you this, just so like people, if they're new, people know who they're talking to. Because I always, when people come in the room, I'm like, when I've been at the doctor, who are you? Like, I don't need to know who you are so I can know how much to tell you, right? Like, anyway,
Yeah, so ultimately, I think Western medicine has gotten into this cadence for physicians to kind of diagnose and then write and prescribe. Diagnose and write and prescribe. So why is that like the first go-to? Like, why can't it be like, all right, listen, he's an active kid. Like, I'm using my son as an example. Put him in martial arts. Get him out there on the field. Let him run it out of his system.
Run him around the building for 15 minutes out of each hour.
Yeah.
Maybe he needs to be doing more hands-on work. Like, not everybody should be sitting in front of a desk in a classroom in a concrete building.
Right. Yeah. It's like if I buy like a lab or a German Shepherd, that dog's got to run.
Are you saying our kids are dogs?
In a way, yes. But beyond that, these animals need to run. They gotta go.
Stallions.
Yeah. Mm-hmm. So the first impulse should not be, there's a drug, there's a pill that I can prescribe, and if you give this pill to this kid, he'll be able to pay attention. It's so backwards, right? It's crazy.
Yeah.
And yet it's accepted. And now we have a $5 trillion ecosystem.
Follow the money.
And $1 billion of that is drugs. Mm-hmm. Yeah, 100%.
Follow the money. Did you see the stuff, by the way, going around? I probably shouldn't say this, but I have good friends who are working in PBMs, but there's a bunch of stuff circulating now. Somebody just posted about how, do we even need PBMs? They should just be, anyway. But that's just another layer of the cake. But
well, getting back to your story though, because we'd get off on a tangent. So you're kind of in puberty, going through it all, and you're under tremendous pressure. And what causes you to seek treatment?
So again, I was about 14 when I was diagnosed, I think, with ADD, and really at the time I needed yoga and meditation. And my parents are amazing, by the way. I just want to say this here because they're probably going to listen to this. I love my parents, and they did a fantastic job, and they really are the key to why I ended up okay today. Because not only did they care enough, but they also had the resources to be able to get me the care that I needed. It was very confusing at that time as well because ADD was a relatively new diagnosis. I mean, I was born in 1983. And so it didn't really explode until I was put on stimulant medications by, I struggled around 18, 19 years old, and I started with my eating disorder. And the psychiatrist that I was taken to was like, oh, she just has ADD. Just solve the ADD problem with stimulant medications. And then, she'll be good. Right. And so, the stimulants were great. They turned off the food noise. I got hyper focused. It was great. I didn't realize how agitated I was coming off of them, but
right.
And I went to Europe, and I ended up transferring to a university in Europe, to Franklin College, where I'd finished my university. And I had a doctor over there that just, kept prescribing sort of, and I realized like I was so dependent on those meds. Like I got to a point where I was just like really depressed and suicidal, and I couldn't get off of the stimulants. I was
God.
physically dependent on the stimulants. I couldn't get off. I mean, they were giving me a long-acting stimulant and then a short-acting in the evening, and it was horrific. And I came back to the U.S. eventually, and
What is the derivative of that drug? Is it like pseudoephedrine, or is there?
It's like a meth. It's like meth,
right? Yeah.
It's amphetamine salts,
and
like Adderall or amphetamine salts in different forms.
Right. And so you saw Breaking Bad.
Yeah.
Right? So
yeah.
Like if you get enough Sudafed, right?
Yeah.
You can basically make meth. And they actually went and they got barrels, 55-gallon drums of the actual, chemical.
Yeah.
But that's not good for you. And it's highly addictive.
Very highly. I just can't believe that they're running around touting that it's not. I mean, the problem is this. We were talking earlier about how we both subscribe to Jordan Peterson, and David Eagleman does a great lecture on brain plasticity on there. Did I say that right? Brain plasticity. Yeah. And he really calls the brain more like a live wire.
Mm-hmm.
And it is a live wire because I told you about this experiment with the ferret where they, you have the visual cortex, the auditory cortex. Visual receives vision, auditory receives hearing, and they just switched the input. I don't know how they did this. Don't ask me how. And they put the vision going into the auditory cortex. And the auditory cortex became the visual cortex. So it adapted. And one thing that we just do a piss poor job of in Western culture in general is teaching how to be present in the moment. Our entire culture, if you think about it, was sort of founded upon like, if I just go west and discover that gold, things will be better in the future.
Right.
I can be wealthier. I can be like, it's a culture of consumerism, and a lot of people don't like to hear this, but and it's a culture of not being in the present. And I see this a lot, especially now, because I've taught yoga, but I finally decided to go through an official 200-hour teacher training certification with a trauma and somatic informed component, and I'm finishing that now.
Because you don't have enough on your plate.
And so it became even more evident as I was going through this training, as I have been, and just like the distinguishing factors, whereas the concept of like, does depression and anxiety really exist? And this is very controversial, and you might get some hate mail for this. You're probably going to get hate mail from me coming on as a physician saying I don't like stimulants either. But like, does depression and anxiety really exist as a diagnosis if you are able to be in the present moment?
Mm-hmm.
Like if you're able to be in the present, then what you're experiencing as sadness in the present is sadness in the present moment.
Mm-hmm.
Is it constant? Is it depression? The other concept that we need to distinguish is between permanence and impermanence. So there's a lot of talk in Buddhism about the impermanence. Everything is impermanent. Like our conversation, our just being together now is impermanent because I'm going to leave. This cup is impermanent. Eventually, well, who knows if it's going to biodegrade.
It's going to take a while.
Yeah, it's going to take a little while. But it is in the end. And so that concept of like, does a diagnosis exist if we acknowledge the impermanence of everything?
Mm-hmm.
I don't know the true answer to that. I do know that a lot of people really struggle, and I also do know that there's really a lack of care available in the arena of, when I have a person that comes to me with anxiety and depression, I'm like, I think we should get you into yoga therapy one-on-one. I have a great yoga therapist who I refer to. But it costs money.
Sure.
Insurance doesn't cover that. Insurance is not in the business of keeping you healthy.
No.
They benefit from keeping you sick.
Yeah.
And like just meditation and teaching people how to calm the mind, because I think that needs to be step one in how we deal with mental illness.
Well, the other thing that I've kind of researched and I'm starting to go down the rabbit hole of is just the idea of alternative therapies like ibogaine and ketamine and psilocybin. And there's remarkable, work that's being done with, soldiers that are coming back from war that are struggling with PTSD. And, there's hard scientific data that shows that, it rewires your brain. The neuroplasticity, it's changed when you take these drugs that grow naturally. So no one's profiteering off of it, right? In terms of the drug manufacturers are not putting it out there because whatever, they're class 1, narcotics or whatever the classification is. They're prohibited and they're not in the public domain. And I would think that there's probably a good reason that they're not in the public domain, because if you could take a plant-based medicine and be cured in no time at all, then you don't have a need to continue taking the prescription over and over and over again.
100%.
And so I think we're on the verge of kind of a new era. At least I hope we are. I'm encouraged by the new administration and the direction that they're going. But I always hedge that bet and say, it's a $5 trillion business, and there are a lot of entities, powerful people that want to keep things just the way they are. And so I would not bet the house on it, right? But I think we're moving in the right direction. And if we're really talking about putting the patient first and what's best for the patient, at the very least, it's worth exploring this stuff.
Yeah.
As opposed to putting them on, psych meds.
Yeah, and I want to say, it's not that I'm against medication. I think that medications can be useful. I do think that it's important that you, as the consumer, as the patient, you understand all of your options. I think it's important, and that's why I practice more integratively as well. That's why we made the commitment that direct primary care or advanced primary care is our base, but we said that we're holistic and a little bit more integrative and more lifestyle medicine based, because I realized that, my youngest, she just had a terrible case of impetigo. Do you know what impetigo is? It can be staph or strep, basically overgrowth on the skin, and it looks terrible. It's just terrible, and it's a little bit difficult to get rid of. So this is an example where I posted a picture because, as a mom, it's funny how I still do this. I've dealt with impetigo thousands of times for my pediatric patients, but this is my kid. So I posted for some second opinions on my physician moms group, and incredible how many people were like, she needs oral antibiotics. The topical, she needs oral antibiotics. And I just said, it just doesn't feel right quite yet. I think I can, so I took the mupirocin, which is the topical antibiotic, and I kept that on, but then I also added in tea tree oil salve, a high-quality tea tree oil salve, and a homeopathic remedy called Mincer. And voila, within 3 days, it started to clear up.
Wow.
And I think that's a powerful example of, I didn't have that information, or I didn't have the time to get that information when I was insurance-based doctor. I didn't have the mental capacity when I got home from work. I mean, I was working urgent care, I'd done outpatient addiction medicine, primary care. And in any of the settings, I really didn't have the energy or the desire to do it because I was so burnt out.
You drained.
And when you have time, I'm constantly looking new things up so that I know how to present it and saying, listen, if you want to try an antibiotic, we can do that. But these could be the other options too. And I think that you have some time to try out the other options before jumping to an antibiotic. What do you think?
Right.
Right.
Yeah. And, to be clear, I'm not anti-medicine either.
Yeah.
And there are some great use cases. Antibiotics are miracle drugs, but I think the problem is they're overprescribed, and you're carpet bombing your microbiome.
Your
microbiome.
Yeah.
And that's not good. So you just for your own health, you want to be judicious about how often you're taking antibiotics. You want to kind of use it as in case of emergency, break glass, not as, I have bronchitis again. The only way I could overcome this is take an antibiotic. It's really tough, because there's so much misinformation out there. You don't know who to believe anymore. And if, telemedicine is a big thing, if you're calling a telemed doc and you describe your symptoms and conditions, maybe they easily prescribe, antibiotic, and you get someone else and they do it again, and you get someone else and they do it again.
Well, I have a question for you on the overprescribing.
Yeah,
Let's
sure.
talk about the overprescribing. Okay.
Yeah.
If you thought you needed an antibiotic or you were worried, and two things were real for you. The first is that you call in and you get a physician that you have zero relationship with. You don't know them. They could be some jackass on the street, like don't know what they're doing, right?
Yeah.
So you have no relationship with them. And you know that after you see them for 5 to 7 minutes, maybe 10 minutes, that you're not going to be able to easily get a hold of them again. And you've been waiting for however, I don't know, half an hour, 45 minutes, an hour, sometimes 2 hours. Would you want to go home without an antibiotic?
Yeah. No, you almost feel defeated. Like, I walked away with nothing.
No. So, I mean, that was the whole thing. When I worked urgent care, I was always amazed at, wow, these people are coming to ask for my advice, but I really don't have a relationship with them.
Right.
They don't trust me. They don't know who I am. I don't know who they are.
Yeah.
And of course, they're going to want to go home with an antibiotic, because if they get worse, they don't go home with it, and they get worse, they have to repeat this process all over again.
Yeah.
So I think that concept of overprescribing is not like anyone's fault other than the health insurance cartel. I think that once you open up a space for time, and my patients know that once I get on the phone with them when they're sick, and it's always same day for the most part,
right?
That we talk over a plan, and I can either send it and I know that they'll message me if they're going to pick it up and take it, or I cannot send it and they know that they can just shoot me a message and I'll get it and I'll send the antibiotic through when they need it.
Right.
They know that they can get me on follow-up, and I think that changes the whole concept of overprescribing.
Without question. So I want to unpack that. But so I had Warren Moon on. I don't know if you know who Warren Moon is, but he is he ran like, I don't know, 5 hospital systems by the time he was in his mid-30s. Very interesting guy. And now he coaches CEOs, and he talked about the NUCA system. Are you familiar with the NUCA system?
No, NUCA
So
system.
this is a healthcare system that was created for the indigenous people of Alaska. And so they created an ecosystem, including hospitals, doctors, providers, et cetera. And at the heart of the system, and what they kind of started with, what does the patient want? And it was number one on their list. They wanted to have a relationship with their doctor. They wanted their doctor to be like a friend who was sitting with them at their table. And this system is like unbelievable. There's no waste, fraud, and abuse. It is self-contained, and it outperforms our healthcare by a exponential margin.
It's direct primary care.
So talk to us a little bit about direct primary care. So what you just described, most of our audience probably doesn't have a clue, right? So people that are in our circles who are tuning in know what direct primary care is. But explain this to our listeners and our viewers who might not be familiar with what the hell we're talking about.
Yeah, I know a lot of. So I think the easiest way that I describe it, at least, is it's affordable concierge care. And I hate saying that word concierge, because I think concierge is really known for like their double dipping. They bill you the monthly membership fee, and then they bill the insurance as well.
And it sounds expensive.
It sounds expensive, and ours is not. I mean, our membership for adults is $99 a month. We might be going up to $109 in the new year, but we're going to try to hold there for a long time. And it's cheaper for kids as well. We have family caps on that, and so you can use it. Basically, what it does is usually when you go to the doctor, and you probably already know this, the doctor bills the health insurance cartel for the visit. And then they receive payment for the visit. You might pay a copay when you show up, but they receive the majority of their reimbursement from the health insurance company, and that could happen 3 to 6 months later. We don't do that at all. We just basically said no to all health insurance, and that way they don't control how I'm seeing my patients. A typical primary care provider in the insurance-based system in our area in Pennsylvania has anywhere from 2,200 patients. Let that sink in. So over 2,000 patients to 2,500 patients on their panel. If they're lucky and they're like maybe in the latter stage of their career and they don't care really about money, maybe they have less than that. But as most of our primary care practices have been gobbled up by large hospital systems, which, by the way, I always ask this question, like, did Jefferson buy Health Partners or did buy Health Partners buy Jefferson? It's sort of like, but as they're gobbled up, that's not really possible because they're basically just firing those doctors because they're not able to. Most primary care practices don't even make money for the hospital system.
Yeah.
They just simply are almost like advertising and a way to pull people into that system and keep them in the system. And then they make it as difficult as possible to go outside of the system, right? Like it's very difficult to get records from Jefferson. It's very difficult to get records from Penn. They want to keep people in the system.
And it's difficult to get appointments as well.
Very difficult to get appointments. In fact, remind me to talk to you about the open communication network that I started.
Okay.
That was another one of the things that we have like over 52 doctors on there.
Right.
Really exciting.
And so if I could just interject, what you're describing is kind of like a Netflix subscription for doctors, right?
Exactly.
It's a good way to think about it. So
Yeah.
you're paying a monthly fee for access to a doc who actually, hopefully, the doc is reputable and good, and you got to do your research. It's like a box of chocolates.
Most of us have meet and greets. You can schedule a meet and greet. I would advise anybody that's listening, don't sign contracts for a year. I mean, we don't own people. Like
Right.
if this is your body, this is your health, this is your mind, this is your spirit.
Right.
If it's not working for you, you should be able to take your money and go elsewhere.
Yeah, no. So I'll share with you that I, signed up for a direct primary care physician. They're not easy to find in New York City. I'm actually, I found a doctor in Huntington, which, typically we can get there in about 40 minutes, but with traffic, it could be 2 hours. But the experience so far has been wonderful because he's extremely responsive. Send them a text, you get a reply. Need a prescription filled, it gets filled. Same day. This is communication with the doc, and it's like boom, 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 boom. So, there's a price to pay for it, to be sure, but man, like there's no waiting 2 hours in a waiting room to see this guy. He's available. You set an appointment. He's going to be there at the time, going to see you, going to spend time with you. My intake with him was probably an hour, and he was willing to spend more time. I had to go.
Yeah.
I was like, I got to get the hell out of here.
Yeah.
But I don't think the average person realizes that you exist.
Interesting. Yeah, it's really interesting that you said that. I think a lot of our growth has been mainly just word of mouth because I really haven't put much money or any money into advertising. I mean, I got a website that's supposed to be SEO optimized. Who knows how that's working? But
that's a rabbit hole in it.
Yeah,
it's a conversation for another day.
Yeah. And so I think people also have to remember that typical DPC doctors have between 400 and 600 patients on their panel.
Mm-hmm.
It just depends. Some DPCs sort of span, like concierge care could be 100 to 200 patients on their panel, but they're also charging $2,500 to $5,000 per year per individual.
Yeah.
Right? And so I think it really is a manageable number of patients. And that's how it should be. I tell all of my patients, I say, listen, if you're sick, I'm getting on the phone with you at minimum the same day. I mean, I might not be able to see you in person if I'm already at home and I got my kids running around, but I'm going to get on the phone with you and we're going to work it out. And then worst case scenario, you just pop in the next day if you need something. So,
and when you think about it, with technology, it's so much. I mean, really, like, do you need to put a stethoscope on them? If you do, then you got to go in. If you need to measure blood pressure, and you do, you got to go in. If you need to look in my ear, and you do, you got to go in. But a lot of this stuff can be kind of triage right over the phone or right over.
I have news for you. There's home kits now.
There's home
People
kits.
can get where we can get like a listen to the lungs, a listen to the heart. We're working on getting a better one developed for the practice. But
is that pricey right now?
So TytoCare had one out. I don't know what happened to that company because it was actually a really good kit, and then they just sort of can't get a hold of anybody. And Nonagon was another company that had that. But now it was like $200, $290, and you use it on the whole family.
Right.
So, and it lasts a lifetime once you have it. So no, I don't think that's really an issue. It can do a full physical exam, basically. I can hear your heart, your lungs. The other thing is, like, people don't realize this, but insurance often doesn't reimburse for a phone call. So providers that are in that system, they're dependent on that for their paycheck. Like they have to bring you in to bill for a visit. Whereas a lot of this stuff, I did a lot of telemedicine also through Amwell, and they have really good training. The whole process is stinky because it's like, they pay you like $25 a visit or something. So you're just trying to churn through patients as quickly as possible.
Right.
But there's a lot of stuff, like you said, that can be handled via telemedicine, especially if I get a visual on you. I mean, a pulse ox is $20. It'll measure your oxygen and your heart rate. Like I can pop over to the pharmacy, grab one if you have respiratory symptoms. Let's just make sure your oxygen's okay, and then we can sort of formulate a plan after that.
Right.
So lots of different options. They even have EKGs.
Right.
In my office, I have an EKG that's like this big, and it's just you put your thumbs on it, and then there's a portion on the back, and you put that on the skin of your left knee or your left ankle, and I can get a 6-lead EKG. Boom, done on my phone.
And it's accurate, dependable?
Yeah.
Wow, that's pretty cool.
Mm-hmm.
Yeah, so I think, and if you're an employer listening or watching, when you have DPC embedded in your plan, it is an expense, to be sure. It's going to jack your rates in terms of the hard costs that you pay for your plan. But, there's a big but, in the long run, you're doing yourself a tremendous favor, because I've seen it firsthand. You put in DPC, now if there's something that is required, a specialist beyond your scope, and people don't realize that most of the physicians who are doing what you do, you wear more hats than a typical doc that's kind of got the blinders on. So there's a lot of ground that you can cover. But outside of that, now we have a team that can help triage care. So, let's say we have someone that, I don't know, maybe they see you and they have a fracture. And if it is beyond your scope, they need a referral to an orthopedist. Our team can look at where the quality is highest, the cost is the lowest, and where there might be a direct contract. So instead of, using New York as an example, sending that patient to Hospital for Special Surgery or NYU, where, it may cost, if it's something that requires surgery, right? A surgical intervention, a compound fracture, something like that. Maybe the ticket in one of those hospitals is $120,000, and we could find the same surgeon that does the procedure, that has operating privileges at a freestanding clinic, freestanding surgical center, and the price for that surgery is a fraction of $120,000. Maybe it's $30,000. So you're saving your plan a tremendous amount of money. You're delivering the best possible care to the patient, and everyone is winning except the insurance company.
Yeah, it's incredible. Like, I think I want to give a shout out to Scott Conard at Converging Health and John Bushman, because they just did something incredible. Scott, they're both DPC docs, and Scott runs, he's like a data genius, this guy. Hi, Scott. I don't have any financial ties to these guys either. And John has been an amazing mentor for us in this field, and we're so grateful for him. But they presented at at Rosetta Fest in Denver. So Scott came in and just did a simple analysis of John's practice and said, okay, using his data analytics and saying, just by incorporating DPC, direct primary care, into a health plan for an employer, what happens to total cost? Like, they didn't change anything else. They still standard Blue Cross plan, but they were able to show that they were able to save at least 50%. I think it was around 50%, maybe. Correct me if I'm wrong. I want to see if I can borrow those slides, by the way, guys. But because I want to show those to employers, it's really important. But part of the way that you can do that is when you use data appropriately, you can find patients that are, Scott divides it into one of 4 categories. It's like there's a low risk side and a high risk side, and then there's like I'm totally butchering this, but you can basically get the patients that are like the highest risk patients and try to get them in. You proactively make contact with them and say,
Right.
hey, we've determined that, like, you wouldn't say this to them directly, but you can determine that these guys are at the highest risk. Let's get them in for more regular care so we can bring the risk down.
Yeah.
I mean, this is a prime example of like how I had a patient who I just inherently, and I haven't implemented this data yet into my practice, but knew he was at higher risk. So I talked with him and I sent him for a coronary angiography with an AI analysis using HeartFlow. I work with HeartFlow specifically because they were willing to give me access to this 3D models because I want to be able to sit down and review it with my patient. I know I'm not the cardiologist, but I am their doctor.
Right.
And I want to be able to sit down with them and show them, well, this guy was able to like transform his life because he realized, oh my God, he's got like a 90% soft plaque burden and he was about to have a heart attack if he didn't do something. And this was like a wake up call for him.
Right.
And we were able, I mean, he's now working with a trainer, he's lifting, he's eating well. Like this when you can identify those patients and give them data in some sort of meaningful way, people will make change. It's the same concept as like taking people who are obese and having really struggling with food intake, right? Food noise. Just put a glucose monitor on them.
Yeah.
And have them see there's a correlation in the brain. This is just positive habit coaching. Like that's our brains are we like to think that they're so developed and they're not. We still have reptilian brains. Like it's almost like the more developed we've gotten, the less developed our brains have gotten in so many ways.
No, 100%.
Yeah. So once you see and you correlate, oh, when I eat this is what happens to my blood sugar.
Right.
And then you can start to make those lifestyle changes. So, I mean, just by doing nothing other than adding DPC. Now, obviously, if an employer is completely fully funded in, a Blue Cross plan, they're not going to see those savings likely.
Right.
Maybe, but
right.
But that's important.
Yeah, well, so a couple of things there. So I had the privilege of interviewing Dr. Jack Wolfson, and he's a natural cardiac doctor, surgeon. And, he started out as a traditional board-certified cardiologist.
Here's your statin, here's your statin, here's your statin.
Yeah, I don't know if he was that free with them, but now he, rarely prescribes statins. And so, knowledge is power. And so just in having a conversation with him, he said, Ray, a statin will reduce your LDL, your bad cholesterol. He said, but the point of taking the statin is to reduce the risk of heart attack and stroke.
Your 10-year risk. We have a 10-year risk calculator
right.
that we use based on cholesterol and other things.
And what he told me was, depending upon which study you read, it's going to reduce your risk by, I'm going to put you on the spot. Do you know?
Oh, man.
Less than 2%.
Yes, it was something low like that, yes.
Correct.
Yep.
So if you're floating around out there taking Lipitor or, a statin has been prescribed, would you, first of all, did you have that conversation with your doc? Did your doc say, hey, your numbers are high, your LDL is 250 or, HDL is, not so bad, but we got to get this under control? And did they just prescribe and you believed your doc and trusted because your doc is God, put your doc on no offense, put your doc on a pedestal.
I understand.
And you start popping these things. Would you have gone down that road had he or she had that conversation with you and said, ultimately, we're going to, put you on this to reduce your number, but the actual risk reduction for heart attack and stroke is less than 2%? Because I would listen to that. Thankfully, I don't have high cholesterol, but I would listen to that and I would say, hell no.
Right.
No, I'm not doing that. Right. But I don't think that conversation is had in the mainstream. And so
there's no time. We so underestimate time in Western culture. There's no time. And those are the patients who, I will always encourage them to get this CT angiogram. It is some radiation.
Mm-hmm.
It's sort of like the equivalent of 2 or 3 years of background radiation, like just the normal radiation you get going through life.
Right.
But the scan is really intended to probably be done like once every 8 to 10 years.
Yeah.
And I've encouraged most of my patients, and they say yes, it costs $1,500. But I always like to put that into context. Like, how much did you pay for your car?
Right.
How much did you pay for your house?
Yeah.
This is your body, right?
Yeah.
Of course, insurance doesn't pay for it unless you're already symptomatic. At that point, it's too late. But it basically gives you everything that you would get from a cath.
Yeah.
And with a cath, for people that don't know this, they're snaking a tool up your main artery.
Yeah.
And it's really high risk procedure actually. Yeah. And I think I read somewhere, and I know I'm going to get hate mail for this, but I think like 40% of patients that go to the cath lab and actually have a cath are like negative.
Right.
So we've now performed this really high risk procedure on 40% of patients that didn't really need it.
Right.
So this test for $1,500 gives you all of this information. And if you have high cholesterol, but it's not affecting your coronary arteries already, like there's no plaque deposits, it shows if there's any obstruction of flow.
Right.
And if you have plaques, but not only plaques, but if they are high risk or low risk. So just so you know, if you have a really hard plaque, a calcified plaque, it's less likely to break off and go downstream and cause clogging.
Yeah.
Whereas if you have a soft plaque, that's really a much higher risk plaque because it's more likely to break off. And so,
And it gives you that information with the sophisticated
a
test.
full 3D model, you can see where all of the you can see almost everything.
And once you have this information, is there an intervention? Can you do something about it, and what would you do? What would be prescribed in that case? Let's say you had soft plaque.
Right. So this patient that I tested recently had like 90% burden of mostly all soft plaque. And so in that situation, thankfully he wasn't having any obstruction of flow, because you can see it's called fractional flow. There was no obstruction. And so in that situation, we could come in like hardcore with the lifestyle modifications, because he was not taking care of himself. He was not eating well. You need fats, by the way. You need cholesterol to make all of your sex hormones. Hello, testosterone.
Who cares about sex?
Right, exactly. Testosterone, progesterone, estrogen. Like you need those hormones, or you need those fats, and you need the fats also to help with protecting the nerves in your brain as well. There's so many things that you need. These your cells are made up of lipid fat bilayers, they're called. So like these are beneficial to us, and so I would say your question about like what do you do, it depends on the circumstance. I had another patient who was completely asymptomatic, low risk. We thought low risk, and she ended up having a 40% blockage. So now we actually have cardiology monitoring that, and she was already pretty good about her lifestyle choices, but she was still vaping. So this was like, we got to cut the vaping. We know that vaping is a huge risk factor. We have to figure out how to do this, because we don't want that to get worse. And we're monitoring that now. With cardiology, once a year, once every other year, to make sure it's not worsening. So we're catching these things before people need open heart surgery with bypass or like major stent placements and everything.
Right. Yeah, we have a guy in the neighborhood, and it's no secret. They have a deli that's very close to my house that's famous in Whitestone. And his brother passed at 40, he's in his mid-40s. He went out, did some shoveling, came inside, cold to hot, passed out on his bed, gone, widowmaker. And so he's got two brothers. There were three boys that I know of. And I go down there the other day and talk to this guy, and he's like, yeah, I had a heart attack. And this guy's fit. He weight trains. He's, in good shape. Probably saved his life, he said, because he was experiencing chest pains, was able to call and get help. They took him in, and crisis was averted. But there aren't enough people that are proactive about their health. And I believe that our system is very reactive. Our system is a sick care system.
Yeah.
It's not a healthcare system.
Yeah.
And so we don't have docs like you, unfortunately, that are in a position where they can kind of slow the music down, have a conversation, learn what's going on, and then be prospective about getting ahead of stuff, like with the test that you described. And we got to get there. And what's amazing for people who are listening and who are hearing this is that it's available. You don't have to stick with that DP, even if you like your doc. And there are plenty of good physicians that are working in the traditional model, more good than bad, I would say. But there's only so much that they can do in that model and in that system. And seeking out the advice of a physician like you that is just fed up with the status quo and done with that, you literally can save someone's life. I mean, the other thing that Dr. Wolfson shared is, instead of a statin, get outside and get sunlight. Expose as much of your skin as possible to the sun and do it every day. We have this great, fusion reactor in the sky that will hit your skin. It will generate vitamin D. It will convert to cholesterol, good cholesterol, which is needed for the function of all of our cells. And so get outside and get sunlight. How many, like heart docs do you think are saying that to their patients as opposed to just writing the prescription?
I can't answer that question because they might be watching right now.
Yeah, we're both going to get hate now. So but it's amazing to me that you kind of found your path at 28 years of age, and you did work in the traditional model for a while, yes?
Yeah. I mean, until a year and a half ago
So
that I was still in that model. I felt stuck.
And so how do you feel now? A day in the life now versus a day in the life when you were in working for the cartel?
I feel free.
It's
amazing.
Would you advise your colleagues that might be listening to take the leap, take the plunge? Is it all roses?
No, I would not advise them to take. No, I think that it takes a certain personality, and you need certain supports to be able to do it appropriately. That's why we took our model back to the drawing board, and we just opened a second location because we hired another provider who she's just not she doesn't want to be an entrepreneur, and that's a lot of people don't want that. They don't understand what it takes, all the behind the scenes stuff. And so I realized, okay, we'll make less money, but I can actually, using a very low overhead model, open up a clinic and bring lifestyle medicine to the providers as well. So if I find a provider who's in line with what we're trying to do and they're the right person, our goal is to open 10 more clinics in the next 3 years, because it's really important. Most providers that find me are probably going to be a parent, at some point in their parenting cycle. And I think that it's really important that your work is close to your home, especially in this field. Because if you forget something at the office, or I had a patient that they needed a medication or something, and I was like, no problem, I'll just run over to the office. I'm going to put it outside for you. That way you can just pick it up whenever you want. That's really important, to be close to home. If you forget something, you have a kid and you need to run back real fast, your kid's screaming in the car, a 10-minute ride versus a 30-minute ride each way, that's huge, right? So I guess, yes, I would encourage them after they've thought it out and they really understand the business part. I could not have done it without Tommy. I just have to put that out there. I would have been completely overwhelmed and I might have quit, because it's really important to have that support. But there are more organizations, like John Bushman has an MSO.
Yeah.
And he assists other clinics in transitioning over. And they basically use the resources of his managed service organization for DBC practices. Yeah. Which is nice. That's an option as well.
Right.
I think you really just need to read the book Traction by Gino Wickman.
Okay.
And he talks a lot about figuring out who you are. Are you a visionary, or are you an integrator? There's another book that's oh man, hold on. Hold on. I have it.
You're good.
It's an entrepreneur.
And so Tommy was supposed to be with you today, but you guys have so much going on that he just couldn't make it. He was like, I can't.
I'm gonna put in a plug right now for he's doing a weekend workshop with the Mankind Project.
Oh wow.
And I'm really excited for him. It's all men basically, and he's going to West Virginia and camping out somewhere and
doing man stuff.
Yeah, I think it's really important for us to, and I know, man, this gets into that whole other, how do you identify? But if you identify as a man or you identify as a woman, and I don't know any other way because I identify as a woman, it's important for us to have supports that are the same gender, right?
Yeah.
That are the same. And I think that
you got to have your people.
Yeah, I think men in long-term relationships sometimes can get lost. And it's harder these days because there's kids involved and there's exes and there's work and there's the pressures, and I think it's so important for men to maintain solid relationships with their male friends.
Yeah.
I also really subscribe to the fact that you become the top 5 people that you surround yourself with.
That's
Is that
so
not true?
It is true.
If you're hanging out with people that are not on your mission,
yep.
And man, we are on a mission. you're not going to get where you want to go. I need to really, and I really need to hold those people close to me. I got off the phone with Alex Sommers today. Before I got off, I just looked at him and said, I'm so grateful for you. Thank you.
Shout out to Alex.
Shout out to Alex because he
identifies as a man, I think.
Yeah,
right?
yeah,
okay,
I'm pretty sure. I didn't actually have that conversation with him, but I'm pretty sure just based on what I know about him.
Right.
So that, by the way, that got started with a game of pickleball.
What?
In Denver.
Really?
So I had talked to Justin Leader out in Hershey.
Okay.
Broker. That was connected to me through Lynn Ann, through Health Rosetta.
Health Rosetta, yeah.
And he suggested, people tell me to talk to people, so I just call people up. I don't even know half the time what I'm calling them about. I'm just like, hey, I just want to talk to you. Tell me who you are.
Good for you.
So I started texting with Alex shortly before Rosetta Fest this year. And my cousin owns the Gates Tennis Center. He runs the Gates Tennis Center in Denver, Colorado.
Okay.
And so I said, listen, what time are you getting in? If you want to just come, do you play pickleball? We're going to play pickleball at this time. It's before the conference. Like, come play pickleball. And this guy shows up.
Yeah.
And
right on.
we had a great time. We just played pickleball with me and Tommy and my cousin Sam, and it was a great day. And that's how the relationship got started. It was really nice.
And so now he's a colleague. He's another DPC doc.
He's a genius. This guy's a genius.
He's got it all going on. No, but you know what? That's just a great lesson though, because some people can't get out of their own way, or they just let fear overcome them. And they don't make those calls. They don't reach out, to someone that, maybe is a peer that can give them some advice. And it gets in the way. And, kudos to you, because you're not letting that get in your way. You're taking the initiative. You're picking up the phone. You're reaching out to people. That's how you learn. I saw you out there talking to him and a group of docs, and you're taking notes, and you're a student of the game, and that's how it happens.
Student of life. Yeah, that's really important.
Episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today.
And I do want to say, a lot of these topics are touchy. I think I want to always say there's somebody that's done this before me, and I really need to talk to them because they know way more. That's why we called you too. Or what we need to know what do you know? Tell us everything.
Right.
It's so important to acknowledge
and
that.
You still came.
And I still came. Yeah, I still came. Yeah. But I want to, I really wanted to sort of check in with you about, we've been up against a lot of struggles in Pennsylvania specifically.
Yeah.
People are so fearful of so many things. And I know we were talking before about this I think it's absurd. If you are an employer and you have not at least gotten an alternative option for your standard Blue Cross plan or United or Cigna or Aetna, whatever, if you have not at least learned about your options, this is a huge problem.
Yeah.
If your broker has not come to you saying, this is your option staying fully insured, this could be a level funded option, and this could be depending on the size, right?
Yeah.
I think that's a huge problem. And I see this the most, in talking to other physicians who own clinics.
Yeah.
And these are large clinics. I see so much fear going around and misinformation. And I think that's important to talk about.
100%. Well, that is the main. Listen, I've been in sales basically my entire career. What I'm doing today is by far the hardest thing that I've ever done, because we're dealing with that 4-letter word that starts with F, not our favorite curse word, the other one, fear. And it's fear of, oh my God, if I make a change and I break away from United Healthcare, or I break away from Aetna, or break away from, pick a flavor, Blue Cross, I'm not going to be able to get care when I really need it. I might die. And that's what's going on in people's brains. Or, my wife might have to switch docs, or my husband might need a different, doctor to follow him with his diabetes, whatever the case may be. And people need to reconcile that little insurance ID card dispenses absolutely 0% healthcare. It's just an insurance card. It's just a mechanism that is a safety net that says, in the event that you're sick and you're really sick, you have an insurance policy that's going to back you up, and it's going to step in, and it's going to protect you from catastrophic financial loss. That's what insurance is intended to do. We're not even doing that so well anymore on the insurance side of the house.
You could go into the emergency room for something and end up in the hospital and be seen by an out-of-network doctor and then be totally screwed with the cost.
Correct. So, to your point, unfortunately, unless you're a large employer, if you're a small employer, which in most states is under 50 lives, in New York, California, for example, it's under 100, you don't have a lot of great options. There are things that can be done, but it depends on the risk pool, the demographic. At the end of the day, whether it's a fully insured insurance carrier or it's a self-funded plan that has stop-loss insurance backing it up, no one is in the insurance business to lose money. So they all have to kind of, look at the numbers, look at the demographics. And, if you're an organization that is skewed to the older side, the majority of your employees are above the age of 50, you're not a risk that anyone is chomping at the bit to take on. Same is true of the other end of the swing of the pendulum, right? If you're in your 20s and most of your colleagues are in their 20s and there's no, real health risk there other than maybe preemie babies. So schools, for example, sometimes, get put under the magnifying glass because there's a huge risk of that, and the NICU, claims could be through the roof. Sometimes that will skew the numbers. But unfortunately, there's a big percentage of folks that are kind of caught in the middle, and there's always something that can be done. I say, what makes me kind of go is looking at a case and saying, if I was CEO of this organization, if I was sitting on the board, what are some of the things that I would suggest that at the very least we explore and look at? And that's always my approach as a consultant, because there's always something you could do.
Of course.
But folks have limited options in that in-between space. What drives me crazy is the large employers that are with the big box broker, that are with the fully insured insurance carrier, or they're with an insurance carrier, an ASO arrangement, which means administrative only services only, meaning that insurance carrier is adjudicating claims and, basically self-adjudicating a good amount of claims, auto-adjudicating, I should say, a good amount of claims, which is akin to basically paying a credit card bill on the blind. Like you're not even looking at the itemized bill. You're just paying.
Adjudicating. We have to explain the word adjudicating.
Yeah.
It's like they're basically processing
exactly
the claims. Yeah.
Yeah.
But that gets me into the story I was telling you earlier. We have such a problem in our area. All of our health systems have been bought up. It's like they're all going to go in. Crozier or Chester, did you hear what happened?
No.
That was one of our main hospital systems in the area. It was the only large hospital system that served like the entire southeast portion of the Philadelphia region, Delaware County. They were bought by private equity, sucked the money, closed it down. The entire health system. It served most of our low-income population in the entire city of Philadelphia. There were residency programs there. I mean, we are screwed right now.
That's a huge problem.
And so we've been talking with the only freestanding independent health institution, and thankfully they have a broad scope of service. They do most things except for like very specialty neurosurgery and cardiac surgery. And you would not, I mean, man, I don't want to, I have to say this.
Say it, girl.
This.
Preach.
So they, the biggest player in our area is Blue Cross by far. And they are probably going under. I mean, it's suffering financially because they're chasing Blue Cross down for reimbursement for services. So patients come to the hospital and they're just like having to chase payments, and Blue Cross keeps cutting their payments. In the meantime, the entire 2,000 plus employee population is on a self-funded plan adjudicated by Blue Cross.
Blue Cross. Yeah.
And there, in talking to the higher ups there was significant fear. This was said by their administration that if they dropped that and went to a different form of employer health plan or employer, health insurance, that there would be retaliation in the form of payments. If we're not talking about a cartel, I don't know what we're talking about.
Hey, you guys got to pay this claim or else.
Yeah, you have to use us for your health insurance for your employees, or we're cutting your reimbursement.
Yeah.
On the other end, and this was not an idea created by us. I mean, we were appalled to hear this.
Yeah.
And so there are so many cases like that, and then there's just it's
frustrating. But so the issue, so I'm a capitalist through and through. I love America. I think we live in the greatest country. America. So I think we live in the greatest country in the world. And I believe in free enterprise, and I believe in I believe in a free market system. And to Dr. Keith Smith's credit, Free Market Medical Association would say or suggest that we can have a free market medical system and still do very well. My issue is we're in a system that has the major entities, all of the big insurance carriers, with their fiduciary responsibility and obligation to their shareholders. How could they possibly simultaneously serve their policyholders? They can't. And the same with private equity getting into the mix. Private equity is all about making money, and it's all about the bottom line. And so if the community is dependent upon these facilities for services for everybody, whether you're rich or poor, the hospital is going to take care of you, but you have it run like a cartel where there's no regard for the patient in terms of their financial well-being. It's all about profit for the bottom line. That's kind of fucked up. And that's where we are.
Kind of?
100%. No, it's fucked up.
The other fucked up story is the one that we talked about earlier as well, with the fact that if you are a patient, that the doctors in our area and the systems in our area think that it is illegal to accept cash payment from a patient.
Yeah.
I have had numerous conversations with, and I went through this myself. I had a hysterectomy in February. And I showed up at the surgery center. I said, I want your cash pay price. Oh, we can't. This is what we charge Medicare. We can't charge you less than that. That would be illegal. And I'm like, I'm not going to argue with the nurse administrator there. That's completely false.
Yeah.
And again, it's a system where these. I don't know if they're getting legal advice from the lawyers, and maybe the lawyers are intertwined with the health. I have no idea, or they're just spewing out wrong information.
Yeah.
But now you've taken away the patient's right to choose.
Power corrupts, and absolute power corrupts absolutely. And so that's what you're dealing with. But the thought that you can't accept cash pay is ridiculous. That's patently false. I had Woody Waters, one of the fathers of reference-based pricing. They didn't even call it reference-based pricing when they started.
My mom loves you, Woody. By the way, she listened to your podcast. She was
Shout out to Woody.
Shout out to Woody. She was one of the first female physician assistants ever, so she's famous as well.
Oh, shout out to your mom.
She loves you, Woody.
All right, right on. Good job, Woody. And he kind of talked about it, and it seemed absurd that they had health plans with insurance carriers, and they were paying 6x, 8x, 10x the cost of Medicare. And, they figured out a better way. They kind of stumbled on it. It didn't happen they weren't kind of brainstorming, what are we going to do? Ultimately, they did kind of say, how are we going to go about this? And eventually they settled on, well, we know what a Medicare reimbursement is. And so what if we were to pay them a markup on Medicare? So they should be profitable on what they get from a Medicare patient. So if we pay them 20, 40% above that, if there's any CEO out there listening, you would kill for a 40% margin, right? So That's what they started doing. And, that is kind of the crux of, not a commercial for Imagine 360, but they acquired Woody's company, ELAP. And now that is one of their primary strategies is reference-based pricing. And so the thought that you can't pay cash for services and get a discount over what the insurance carrier is paying is just wrong.
Right, but every patient that walks into those offices and says, I have a really high deductible, I just want to know what your cost is, and we can't tell you that cost.
Yeah.
We can't accept cash because you have insurance. That story has happened over and over and over again.
That's often an uneducated, it's always an uneducated kind of soundbite, right? Whoever's saying that is not in the know.
Well, because they're saying their contract with Blue Cross, United Cigna, and Aetna says that. That's a cartel.
What they're saying that's truthful is, I can't tell you what it costs because they don't even fucking know what it costs. That's the truth. The truth is everything goes through the billing system, and that's a whole spider web that we're not going down that rabbit hole today. But the reality is, if you say that you're cash pay and you get the right person, all of a sudden the calendar magically opens up. You come in, you get seen as opposed to having to wait 3 months. And, there is room for you to be seen by a quality physician, surgeon, et cetera. Pay a cash price, which is always less than the negotiated contract,
like 70% to 90% off
with the insurance carrier. Yeah, it's not uncommon for it to be 10x cheaper.
So in like 2000, when was it? Oh man, it was a long time ago, maybe 15 years ago.
Yeah.
I got billed. Drum roll, please. Do you have a drum roll on that thing?
I don't have a drum roll, but we do that.
Okay. That's ridiculous. For an upper endoscopy, so that's when they go in, they do like a camera to look inside your esophagus and your stomach.
Yep.
$12,000 from the University of Pennsylvania.
Yeah.
And guess what that costs? And this is 15 to 20 years later.
Yeah.
It's like $1,000 self-pay.
Right.
I was able to get, I do have a certain amount of like physicians around me who are willing to give those numbers.
Sure. And that's absurd.
That's absurd. But the majority of people in our area outside of Philadelphia, and these are practice owners.
Yeah.
This is not front desk. They think that it's illegal to give those prices.
Yeah.
And then they won't do it because they're fearful.
Yeah.
Or they're fearful that if they start doing it, that the insurance company cartel will retaliate and lower the reimbursement or withhold reimbursement. If that's not price fixing.
Yeah. Yeah, no, that's nonsense. That's what they're suggesting is, and I'm not an attorney, but I'm going to say that that's illegal. There's nothing wrong with asking any provider, medical or not, for a better price. That's kind of how the world works, right?
Yeah.
And so for them to say that, and it may be true that contractually it's baked into their agreement with the insurance carrier that they can't. But that in itself, as far as my knowledge, with the passage of the CEA particularly, is illegal. You can't have an insurance carrier that is involved in price fixing. You can't have an insurance carrier. There are no gag clauses now. They are supposed to be transparent. You're supposed to have access to your data, which they don't give. There's a lot of shady practices going on. And to your point, it's a cartel. So are we surprised? No, we're not surprised.
Still makes me angry every time.
Of course. But a good guy for you to know, and shout out to my friend Doug Geinzer, is he runs high performance health networks. And he negotiates direct contracts with providers. And so he is someone that knows the ins and outs of that and can help in any particular geography make arrangements. And it's not only good for you as a physician, it's not only good for your patients, it's good for the providers as well, because they don't, again, you're talking to a front desk person that is not super sophisticated or has just been kind of, scarred by the system. And it's not that they're necessarily trying to be deceitful, but they don't know how to give you any other answer. But the reality is, physicians, surgical practices, everybody does better when it's cash pay at point of service. Everybody wins. the only entity that doesn't win is the cartel.
Yeah.
The cartel, and we usually say the cartel are the PBMs, which are owned by the insurance carriers, right? It just goes hand in hand with drugs.
But there are some PBMs that are not, right? Like there are transparent
There are,
PBMs,
yes,
I think, right?
but they're not. So when we refer to the cartel, we're referring to the big three,
The big
right?
three, yeah.
So it's Optum, Caremark, Express Scripts, right? CVS, Caremark, Optum, and Express Scripts control, depending upon who you want to believe, it's greater than 80% of the market share.
Yeah, I read this, and with all the lawsuits that was then the judgment, wasn't there a judgment that just happened against Tiara Yachts that basically was upholding the issue with fiduciary responsibility? I don't know if you saw that, but I read something on LinkedIn. I forget who this was, but they made a really good point. If you are an employer with a fully funded insurance plan,
Yep.
you should not be using one of those 3 PBMs. There's so many other PBMs out there. Go to your broker and ask them to get you off of them.
Well, the problem is if you're fully insured,
They're baked in.
they're baked in. You can't carve them out.
Right.
Right. So
That's sort of messed up because if you're an employer and
It's
you have a
super messed up.
fiduciary responsibility,
of course,
and that's baked into the plan and you don't have any other options,
No.
then, and if you're a smaller employer, you're saying that might need that plan,
right.
then you're
Yeah.
screwed.
Yeah. Listen, I was just I was invited by, I'm going to call him Bertzi because I don't have his last name in my head, but he's a big shot. He's not hurting for cash, been around for many, many years, phenomenal guy, like a real person. And he knows everybody. Like he lives in Trump Tower. He's, friends with the president. He knows everybody. He invited me to this ACVBB, Association for Value-Based Cancer Care. And so I was hanging out with a bunch of oncologists and, service providers, not the typical people that are at the events that are the Health Rosettas and the Next Gens. This was really more with a medical tilt. And they had panels and they were talking about this and that and the other thing. And they had a bunch of, they had a nice mix of people who were kind of on the dark side, on the provider side, people who were in government, and they had one or two of the good guys, I'm going to call them. And they weren't addressing like the elephant in the room, and it drove me nuts. I was like, yeah, I was like,
you had a squishy with you, a squishy ball?
No, but I was like chomping at the bit. So I was like, in one session, they weren't going to ask questions, and I was like, you bastards. And so I ask a question, and I'm just like, you're not addressing the 10,000-pound elephant in the room. I said, these drug companies, which are wholly owned by the insurance carriers, are not incented to reduce claims. People are under the delusion that they are somehow capturing the spread between the premium that they take in and the claims that are paid out. No. That's not how it works. The Affordable Care Act brought into law, the medical loss ratio, the MLR. The more an insurance carrier bills, the more it keeps. So if we're talking about the large employer market with 100 or more lives, 15% of the total package, the whole enchilada, they can retain for administrative costs and profit.
Right.
So as long as it's a bigger number, they get to keep more of a bigger number. We need to abolish the MLR. And so, there was outrage and uproar and, people saying, oh, that's not how it works. I was like, that is how it works. And we need to change it because people can't fucking afford it. They can't afford you and your bullshit. Like, let's go to a physician. It should be like going to a service station where they have a menu, oil change, spark plugs, tune-up, whatever, brake pads. Like, it's not more complicated than that. But you go to a hospital and they have a charge master with 200, different rates for the same CPT code, It's like, come on, what are we doing?
Yeah.
And that's the system that we're in. But you've managed to break away from that.
Yeah, I mean, I to some extent, I feel bad for my patients that are sort of captured in the system still. And I mean, I personally, as a business owner now, I won't support the health insurance cartel. So Tommy and I both have a health sharing plan with Zion Health Share. We also are relatively healthy, and that's helpful. But I have to say, my experience with them, I had been with them for about 5 years because before I left insurance-based care, I was a 1099 contractor because I just got fed up, and I was like, nobody's going to force me to work when I don't want to work any longer. I have good relationships with the owners of these centers around me. I can do it that way, and it worked. But I didn't have insurance, so I took my chances with Zion, and I remember when I signed up. Even there's not even a contract with them. Like, you can cancel at any time.
Yep.
That fear that I felt saying, oh my gosh, I'm not going to have health insurance.
Right.
Like, it was real.
Yeah.
But it was not real. It doesn't make sense, but it feels very scary. And I had been with Zion ever since. And, I went through like 2 years of issues leading up to needing a hysterectomy. And I was totally grateful for them. Like, they ended up, reimbursing me. I paid the first $1,000 out of pocket that I had elected previously. Now, they were 2 separate costs because it was like 2 years apart, for the major costs. And then they paid the rest of the surgery. I paid some of it up front, and then they reimbursed me just because of timing issues. But there was even one time where I had to go in for a procedure before the hysterectomy, and I was able to get an estimate, and they sent me a prepaid card because I already paid the $1,000. So I think that people really underestimate those opportunities if you're an individual or a really small business owner to utilize those. And then when you pair them with direct primary care, a good direct primary care who is also a cost navigator.
Yeah.
I have to say, like, I shout out to all of my DPC colleagues, and there are just some people that just have not gotten on board with this side of it. It is overwhelming starting your own practice, is what I'm saying. So you need to be a good cost navigator as well. You don't need to, it's not one or the other. You can have both, cost containment and quality care.
Right.
And when you make that pairing together, that covers like 90% of things or more that people typically need.
Right.
And if they were to have some, what if I developed this condition that required, I don't even know, millions of dollars of treatment? Well, eventually the health sharing plan, I don't know. They might say, like, this is too much for us to continue shouldering this burden, but you can always, my understanding, and you would know more than this than me, but I think you can now drop back to an ACA plan if you were to get,
Yeah.
So there's lots of options that are available, and it's just, I want to, make that known to everybody. We love Zion. We've had them for a while. But
Yeah. Well, and so you're living proof. Feel like you're a walking testimonial, right? You've had a health event that would have cost you, God knows, out of pocket, thousands and thousands of dollars.
Well, the total cost, let's just do this. So my total cost was a little bit, I think it came in around $25,000 for everything.
Yeah.
And my surgery, it went a little bit long because I apparently am a bleeder.
Right.
But that same surgery, my understanding is, had you gone through health insurance, it would have been like quadruple the cost,
right.
if not 3 to 4 times the cost.
Sure. So what you're describing, for our audience that might not be aware, I might have mentioned this on the show before. I also have Zion Health now, actually.
Zion Health buddies.
Yeah. So, and look, full disclosure, because my wife is my biggest critic, so she still has me on traditional insurance. But knowing what I know about the system, I was like, I'm not using that stuff. And so I said, I preach this stuff every day. I'm using myself as a guinea pig. My plan is not to use traditional healthcare. I'm just going to access healthcare through my DPC and Zion Health, and we'll see how it goes. And, luckily, the concept of Zion, for people that are not familiar, is it's not an insurance policy, right? It's a faith-based health sharing program.
And you don't have to be of the faith to join.
Right, yeah. They're out in Utah. They're probably Mormons, so it makes no difference.
Yeah.
Anybody could sign up. But it's a fraction of the cost of healthcare. And you basically elect a plan based on your comfort level for what your out-of-pocket would be. I think it's 1,000 is probably the lowest, then it might go up to 3,000 or 4,000 per incident, right?
Yes. I think
and-
there's a time frame as
Yeah.
well, but they're very clear about all this stuff. If
Yeah.
you just read through, they make things very clear.
Correct. And again, it's not for everyone. It's not traditional insurance. I'll say that up front. But as an alternative, you're not in the game anymore. You're not in the snags or the snares of a traditional health system where your direct primary care physician is affiliated with the hospital. They're going to send you for a multitude of tests that you probably don't need. They're generating money. They've been turned into glorified salespeople. Now, when they go and get those tests, it counts towards their bonus. I mean, come on. That's the system that we've created. And so, I wish I had a good answer for how to solve this problem. It's a complex problem.
Yeah, and I want to point this out. The one downside to the health sharing plans, if you are a small business owner, is that you can't have a health savings account. Mm-hmm. And that is fucked up.
Yeah.
Like that some people that are working can have it and other people can't. If you're going to give health savings accounts
Right.
to some people,
Yeah.
then you should give them to everyone. And the fact that health savings accounts follow at the BUCA insurance plans,
Yeah, the ACA.
right? Like
Yep.
is right there, follow the money. Like you can only have a health savings account where it's a tax-free piggy bank.
Right.
If you have a high deductible plan from
Yeah.
Blue Cross, United, Cigna, Aetna,
Yeah.
like that's ridiculous.
nonsense.
So everyone should have that. But for right now, that's the one downside.
Effective January 1st, you're going to be able to use HSA dollars for DPCs. So that's coming.
People were doing that already. I think the biggest change it's gonna be with employers,
Yeah.
right? Because it's gonna make it legal for them basically to contribute.
Correct.
Yeah,
Correct.
People were already using, and I think the other thing is the bronze plans right now on the marketplace, and did the catastrophic plan on the marketplace open up to everyone? Before it was only to those under 30, I think, and then I've heard that the bronze, so there's they call them different names based on, they give them colors, right?
Yeah.
So the bronze plan,
Bronze, silver, gold, platinum.
yeah, and then
Yeah.
there's a catastrophic plan that I think was only available to those under age 30 before.
Yeah.
But you can now, I think, as of January 1st, have a health savings account with one of those.
Right.
But I have had patients come back to me recently and say they're expensive.
That's what we call a dog shit plan.
Yeah.
You are functionally uninsured.
Yeah.
Because the people that choose those plans don't have a pot to piss in or a window to throw it out of. And they are basically out of pocket to the tune of several $1,000s before $1 coverage kicks in. Mm-hmm. So it's a scam.
Yeah.
It's a complete scam.
Yeah, and they're actually expensive. Like I pay I'm 42 and I pay I think just over $200. Tommy pays less because I robbed the cradle. He's 2 years younger than me. I was walking when you were born.
You go, girl.
But these plans are coming in. I had a couple patients look into them and they're like $600 a month, $500 a month. So it's a significant amount more than what they would be paying with a health sharing plan.
Yeah, for sure.
And you have to get away from that concept of I'm using my insurance for everyday stuff. Like I need my insurance to pay for my blood pressure medication, or I need my insurance to pay for my primary care visit, or I need my insurance to pay for my labs. But what people don't understand is like we have discount labs in multiple different arenas. I can send people directly to Quest. We can go through Rupa. And I can get the cost of those labs in advance. A general panel, just a standard like Western medicine yearly workup is like $50 to $60.
Right.
It's not expensive. An X-ray, $50.
Right.
An MRI, if you need one, CT scan, all about $400.
Yep.
If you know where to go to navigate the system.
Sure.
And they're frightened.
As opposed to $4,000 in a hospital.
Yes,
Right.
exactly.
Yeah.
Not
10x
even in a
that.
hospital. If you go through the same company
Right.
and you bill your insurance, it's going to come back on I had a patient tell me that he recently paid $800 for an MRI because his insurance covered it, but it was $4,000 and he had a 20% copay. And I'm just like, oh, you would have been better off. You would have paid half of it not using your insurance.
And so normally what we would do is we would design a plan for an employer so that employees would have the option of choosing a direct primary care plan, and the direct primary care plan would be backed up with a reference-based pricing model. And so in that scenario, the employer would pay 100% of $400 because we would send the employee to one of the places that's 1/10 of the price of the system, and the employee pays zero. And that's how it's done.
It's a win-win
folks.
for everyone.
It's not rocket science.
Yeah, people, you should still make money with what you're doing. Everyone needs to
100%.
make money to support themselves.
Yes.
But we should be focused on making money in ethical and transparent ways that are win-win situations for everyone involved as much as possible.
Correct.
I mean, I subscribe to that for everything I do in life with the employment that I'm providing for other people. It's just.
Yeah.
It's so important that we live by this ethical code. And by the way, that book, I realized it's called The E-Myth Revisited.
The E-Myth Revisited.
Yeah, it's by Michael Gerber.
Okay.
And it's a really good book to help you determine if you are in the mindset or have the personality type to be an entrepreneur.
Okay.
But there are more people like me out there. Like there are a lot of DPC doctors that are hiring other doctors, and they
Yep.
all have different ways of doing it. Once you've seen one DPC, you've seen one DPC.
Right.
We're all a little different. Some DPCs are very sort of cookie cutter by the book. I'm a little bit more integrative. And you have to really, I think what you said about having a relationship with your doctor, it's so important to make sure you flow with them,
Yeah.
that you vibe with them, just like with a therapist that you would be talking to, and you might have to try out a few before you get to them. But that book is really good for determining whether you are ready for entrepreneurship.
We'll
or
throw a
not.
link to that in the show notes so
Yeah.
people could find it. So listen, we could talk forever.
Go for another couple hours.
Yeah, we'll definitely have you back again.
I'm going to have some exciting news for you, hopefully, when I come back about
Awesome.
some purchases that we're making.
You're not that far, so we could make that happen.
Yeah.
And until then, how do people find you?
People can find me on my SEO optimized website
Okay.
at Love Health DPC for directprimarycare.com. So
Oh, that's
Love
cool.
Health.
I like that.
I was just like, what do I want to be in this world? I want to be love
Yeah.
and light. So that's how the name was brought up. And on social, we're at still at Dr. Dana. So Dr. Dana Love Health.
Okay.
Yeah. So
Cool. And so, for people that might be like not geographically close, would they be able to subscribe to you and do telehealth and stuff like that? And then, maybe get their asses in to see you if they need to?
yeah, 100%. I am licensed. So as a physician, you need to be licensed in states where the patient lives.
Yep.
So I'm currently licensed in 8 states.
Okay.
And I had a patient that moved to Vermont, and I was like, okay, I'll just get licensed in Vermont.
Right.
And so as that materializes, we can always work out licensing in other states. More than happy to have people. I think that a lot can be done via telehealth. And I always love seeing people in person as well. So.
Oh, right on. All right. Well, Dr. Dana Mincer, DO.
Thank you for having me.
Door opener.
I am very grateful that you think that of me, and that means a lot.
Yeah.
That I have that blessing from you. So.
No, we are honored to have been graced with your presence. We look forward to having you back. And we'll see you on the next one. Until next time, folks. Love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.